Okay, so the topic I want to talk about now is pulmonary hypertension. This is something we talk about or mention quite a lot in ICU, but it can be a bit difficult to get the hang of, and it's something that's actually hardly described at all in the textbook if you have a look. It can be a bit hard to find. So we're going to talk a bit about the mechanisms of hypertension in the pulmonary circulation. We're going to talk about classification of the chronic causes and some of the acute causes and the complications for the right ventricle, this concept of interdependence, and then we're going to talk a bit about the management of pulmonary hypertension. If you think about, one of the ways to think about the pulmonary circulation is to think about just a bunch of capillaries kind of in parallel. Just imagine it like this pile of tubes here, just as a model to think about the different mechanisms that we're going to talk about. One of the things about the pulmonary circulation is that as there's more flow, more of the capillaries are recruited with increased flow. So with a little bit of flow, there's some of the capillaries are open, but if you've got a huge amount of flow, more of the capillaries open up. So it's not, it doesn't sort of strictly follow the simple model of pressure and flow and resistance. Basically, you can, when you double the cardiac output, double the flow through the pulmonary circulation, the resistance actually drops as more of it opens up, so you don't have to double the pressure to achieve the same flow. Having said that, it's worthwhile just revising some of these formulas. That resistance is proportional to the viscosity of the fluid and the length of the tubing that's going through, and inversely proportional to the fourth power of the radius, and also that pressure is proportional to force and inversely proportional to the cross-sectional area. And I want you to think about the total cross-sectional area of the pulmonary vasculature, not just the cross-sectional area of any one particular capillary. The other formula to think about, keep in mind, is what we refer to as Ohm's law, or that kind of V equals IR, or pressure is proportional to flow times resistance. More technically, it's the pressure gradient is proportional to the flow times the resistance. So thinking about the pulmonary circulation, pressure in the pulmonary artery minus the pressure in the pulmonary vein equals the cardiac output times the pulmonary vascular resistance. And if you just add the pressure in the pulmonary vein to both sides, then you get pulmonary artery pressure equals cardiac output times pulmonary vascular resistance plus the pressure in the pulmonary vein. One of the things just to note with these formulas, they're oversimplifications and they strictly only apply to continuous flow in rigid tubes rather than the pulsatile flow in distensible blood vessels. But nevertheless, we stick with the simplifications. Thinking about the causes of pulmonary hypertension, then just going through each of the elements in this equation here, the pressure in the pulmonary artery. The blood flow or cardiac output could be pathologically increased, for example, with a VSD and left to right shunt. That's going to be causing a greater than normal amount of blood to be going through the pulmonary circulation continuously. The pressure in the pulmonary vein could be increased, so that's sort of after the blood's been through the lung on the way back to the left atrium. So anything that gives you an elevated left atrial pressure will give you an elevated pulmonary vein pressure, and consequently elevated pulmonary artery pressure. But the causes of most of the cases of pulmonary hypertension are due to increased pulmonary vascular resistance, and we're going to look at some of the mechanisms why that occurs. If we just think about the definitions of pulmonary hypertension, it's a mean PA pressure greater than 25 millimetres of mercury at rest, measured by right heart catheterisation, and the normal value there is around about 14 millimetres of mercury, although that increases a bit with age and also with exercise. And certainly a mean, so the pulmonary circulation, it's usually a low pressure, low resistance circuit, and certainly a pulmonary artery pressure, mean PA pressure greater than 45 is classified as severe pulmonary hypertension. So the first mechanism to think about is increased thickness of the muscular wall of the pulmonary arterioles. So if we're looking at the example, if it's a normal pulmonary arteriole, the wall becomes thickened, It's a combination of hypertrophy and hyperplasia of the smooth muscle and collagen deposition and some thrombosis formation. And this particular one is what we call pulmonary arterial hypertension. So there's decreased cross-sectional area, thinking both of the individual vessels and across the whole pulmonary circulation, increased resistance and increased pressure. The second mechanism to think about is what if the pressure was abnormally high at the other end of the pipes. And so here, once you think about left ventricular failure. So as I mentioned before, if the pulmonary vein pressure is high, then you've got to add that in and you'll get elevated pulmonary artery pressure. So the things that can cause that could be left heart failure, which could be systolic, could be diastolic, maybe valvular heart disease. Any of those things can cause the pulmonary vein pressure to be elevated. The third mechanism I want you to think about is pulmonary vasoconstriction. So it's not the walls themselves aren't hypertrophied, but the vessels are smaller because they're constricted. This is usually in response to hypoxia or hypercapnia, also acidosis does it. And acutely this is reversible, but if patients are chronically hypoxic, then it's only sort of partially reversible because there's sort of changes due to vascular remodeling. I've called this mechanism number 3.5 because it's kind of related a bit to patients that are hypoxic. And that's basically if there's destruction of lung tissue and loss of the total cross-sectional area. So here, if there's the capillaries and then we get rid of half of them, then the total cross-sectional area of your pulmonary capillaries is reduced. So the situations we're thinking about here essentially is like emphysema, where there's loss of quite a lot of the lung tissue and the pulmonary capillaries. The fourth mechanism is chronic thromboembolic occlusion. So not acute PE, but chronic thromboembolic disease. And once again, there's loss of cross-sectional area if many of the capillaries are filled up with clot. Again, increased resistance. So this occurs in a small fraction of patients following PEs, despite anticoagulation. So just to go through all these things briefly once again, looking particularly at the classification system. So there's a WHO classification system for pulmonary hypertension that basically corresponds to those different mechanisms that we just talked about. So the first one there, pulmonary arterial hypertension, that's the muscular sort of hypertrophy. There's a range of possible causes for that, most likely sort of idiopathic. Second one there, pulmonary hypertension secondary to left heart disease, particularly elevated left atrial pressure and elevated pressure in the pulmonary vein. As I mentioned, could be systolic, diastolic or valvular heart disease. So the third broad categorisation, pulmonary hypertension secondary to lung diseases and or hypoxia. So the destructive conditions, COPD that we sort of talked about, will get rid of some of the cross-sectional area, and hypoxia and hypercapnia will cause pulmonary vasoconstriction. Fourth one I mentioned there is, as I said, chronic thromboembolic pulmonary hypertension. And then there's a kind of miscellaneous category where the mechanisms aren't really clear. So the consequences of chronic pulmonary hypertension are that over time the right ventricle will compensate on hypertrophy, but ultimately that compensation might fail with decompensation, and the right ventricle can be the muscle can become thinned and the ventricle can become dilated, and there's a fall in cardiac output. So some of the signs and symptoms are very similar to just the signs and symptoms of heart failure. You get forward failure and decreased cardiac output, signs of sort of dyspnea, lethargy, fatigue, exertional angina, syncope, and then signs of right-sided backwards failure, so peripheral edema, hepatic congestion, abdominal discomfort. In terms of the investigation, simple things, some of the ECG signs of right ventricular hypertrophy, so make a right axis deviation, some anterior T-wave inversion, right bundle branch block. It can look similar to anterior and inferior ischemia, and you can get that sort of S1Q3 T3 pattern with other causes of right ventricular hypertrophy. It's not necessarily specific for pulmonary embolism. The prognosis of chronic pulmonary hypertension is pretty bad, so that's why it's sort of worth knowing about. Idiopathic pulmonary arterial hypertension has a median life expectancy of 2.8 years. And if you look here, some of those different mechanisms, that IPH, the idiopathic one, is about sort of 50% survival at 5 years. It also affects survival in other conditions. So this is what we more commonly encounter is patients with COPD and pulmonary hypertension. So look there at the survival rates for patients with COPD and different levels of pulmonary hypertension, and you can see that the green line there, for example, if they've got pulmonary pressures, just if their mean pulmonary artery pressures of 30 to 45, then they've got about a 50% 4-year survival rate. If it's greater than 45, they've got about a 10-year 4-year survival rate. So what we've been talking about up to this point is chronic pulmonary hypertension and the right ventricular sort of adaptations in response to that. In ICU, you can also get acute pulmonary hypertension, and the right ventricle doesn't really have the capacity to cope with sudden sort of changes. It doesn't. It can only really accommodate gradually and slowly over time. So if there's sudden increases in the pulmonary pressures, then the right ventricle often decompensates pretty quickly. And so those things can be an acute pressure overload, volume overload, or some problem particularly just with the right ventricular contractility. So the acute causes of the pressure overload or increased pulmonary vascular resistance in ICU, as we sort of touched on some of them already, hypoxia, hypercapnia, atelectasis will cause it, high ventilating pressures, in particular high PEEP, will cause it, we'll see in a moment. And also there can be some endothelial dysfunction and pulmonary vasoconstriction post-cardiac bypass, so the pulmonary circulation can become very reactive in that situation. And also obviously pulmonary embolism and so pericardial tamponade will cause obstruction to right ventricular outflow. This graph you may remember from West sort of respiratory physiology, basically trying to demonstrate the J-shaped sort of curve in the pulmonary vascular resistance. So as the lungs are collapsed on the left side of the graph, there's increased resistance, so that's when when the lungs are sort of got atelectasis. And then on the right, when they're sort of over distended, the capillaries are sort of flattened because they're kind of stretched out, and that also increases the resistance. An example of that would be having very high PEEP. So you've got to try and find a sweet spot in the middle where the capillaries are sort of held open by the elastic tissue of the lungs. They're neither collapsed nor over distended. So the next causes, just thinking back to that equation at the start, that the pulmonary artery pressures are related to the flow times the pulmonary resistance, which we just talked about, plus the pulmonary vein pressures. So the things that can increase the pulmonary vein pressures acutely, which is really similar to the left atrial pressure, things like left ventricular failure, for example, from ischemia, and acute valvular disorder, for example, acute mitral regurg, or an arrhythmia. So these things will increase the left atrial pressure, the pulmonary vein pressure, and consequently the pressure in the pulmonary circulation and the pulmonary artery. Another type of overload for the right ventricle is just plain fluid overload, or also the strain on the right ventricle from a recurgent tricuspid valve. And then thinking about right ventricular dysfunction itself, which may be from RV ischemia, and also post-cardiac surgery or post-bypass, there's often some right ventricular dysfunction for a while, possibly just due to the effects of the cardioplegia and perhaps inadequate cardiac protection of the right ventricle during the bypass. So once this sort of process starts, it can become a bit of a downward spiral that basically ends up with the patient dying, and it can be difficult to kind of intervene and stop this sequence of events. So if we just go through it, the first step then, if you've got increased pulmonary vascular resistance, then that will cause some acute right ventricular dysfunction. And part of the response to that is the right ventricle will dilate acutely because it's just not able to increase the amount of pressure that it generates acutely. The right ventricular dysfunction in and of itself decreases the right ventricular output, and also the right ventricular dilatation will cause some dilatation of the tricuspid valve area. They'll cause some functional tricuspid regurg, and then when the right ventricle contracts, some of the blood's going to regurgitate, and not all of the stroke volume is going to go forward. So that's always also going to decrease the right ventricular output. The right ventricular dilatation is also going to cause some septal shift across towards the left ventricle. So we'll look at a picture in a moment, but that the shift of the septum into the left ventricle is going to impair the ability of the left ventricle to fill. It's going to impair the amount of preload that it can take, and also the fact that on the right there that the right ventricular output is decreased is also going to impair the left ventricular preload. So this is just some pictures demonstrating that idea of septal shift and interdependence. Remember that the whole heart is contained in the stiff sort of pericardial sac. You've got the fairly normal sort of configuration at the top there, and then in the bottom, when the right ventricle becomes dilated and distended and the septum sort of gets shifted over towards the left ventricle, then you can see this sort of D-shaped left ventricle rather than the circular shape which you're normally sort of looking for, and you can see how that impairs the ability of the left ventricle to fill. So we've got decreased left ventricular preload by those two mechanisms, then we're just going to have decreased cardiac output and decreased mean arterial pressure. Remember that the mean arterial pressure, or particularly the diastolic pressure, is important for coronary artery perfusion. And in fact, the coronary perfusion pressure is the difference between the mean arterial pressure and the pressure in the right ventricle. So if the right ventricular pressure has gone up due to the right ventricular dysfunction and the increased pulmonary vascular resistance, and the aortic root pressure has gone down, then both those things are going to contribute to decreased coronary artery perfusion, particularly the right coronary. And as a result of that, you're going to get some right ventricular ischemia, which in turn will cause worsening right ventricular dysfunction, and then, as I said, it just becomes a bit of a downward spiral from there. It can be hard to intervene. So this is just some echo pictures showing what we've just talked about, particularly the flattening of the septum and that D-shaped left ventricle there on the left, and then a kind of apical four-chamber view showing the right side of the heart is very dilated and distended, and certainly if the right side is a similar sort of size on this view to the left side, then it's probably enlarged. Now I'm going to give you another talk later, hopefully, about some basic principles of echo, but what this picture here is showing, if we just outline at the top is the right ventricle, and the bottom there the right atrium, and the colour Doppler, the coloured section there, is showing turbulent regurgitant flow through the tricuspid valve from the right ventricle into the right atrium. And what's being measured, if you look, those yellow sort of curves on the right there, is a measure of the velocity of that regurgitant jet down towards the bottom of the screen. And then you can see there at the bottom it said velocity V1 is 4.98 meters per second. So from the velocity of this regurgitant jet, we're able to calculate the right ventricular systolic pressure. So remember that before we were talking about the definition being in terms of the mean pulmonary pressure and using right heart catheterisation, but certainly when you're doing when people are doing an echo, they can get an estimate of the right ventricular systolic pressure using this sort of simplified equation: 4 times the velocity squared plus the right atrial pressure, particularly if we know what the CVP or the right atrial pressure is. So a velocity of more than 2.5 metres per second is abnormal, and more than 2.8 metres per second corresponds to pulmonary hypertension. Like I said, the last one there showed 4 point something. So in terms of the treatment for acute pulmonary hypertension in the ICU patients, we want to try and firstly treat the precipitating factors. So if there's cardiac ischemia, you need to treat it. Hypoxia, hypercapnia that's causing pulmonary vasoconstriction, atelectasis or excessive PEEP that's causing the capillaries either to be collapsed or over distended. You want to sort of address all of those things. If there's systemic hypotension, then you need to use a vasopressor to try and get that aortic root pressure up to maintain the perfusion of the right coronary artery and the right ventricle. And then you need to make some assessment of the fluid state to see if do you need either more volume or less volume. Ideally, with the vasopressors, you want something that's going to increase the systemic vascular resistance and not the pulmonary vascular resistance. But I think a lot of things we have aren't that selective, or at least we don't necessarily know how selective they are. Next thing you want to think about is trying to reduce the right ventricular afterload, which basically means reducing the pulmonary vascular resistance, assuming that's the problem, unless it's a pulmonary vein or left atrial problem, and then also trying to increase the right ventricular contractility. So things that are going to reduce the pulmonary vascular resistance are pulmonary vasodilators. Now these can either be intravenous or inhaled or enteral. The ones that you'll be encountering in ICU, certainly at John Hunter, basically we've got is nebulized prostacyclin. Other places you will encounter inhaled nitric oxide. Although these seem to work acutely on the pulmonary pressures and oxygenation, there's not a lot of good evidence that they improve outcomes. This slide's a bit busy, but just trying to highlight some of the mechanisms for pulmonary vasoconstriction and some of the way we can sort of try and approach it. Looking there towards the left about the pulmonary vasoconstrictors, the endothelin and thromboxane. So things that might inhibit or block those would block some of the vasoconstricting effects. So bosentan is a endothelin antagonist. And then on the right there, prostacyclin and nitric oxide, as I've mentioned, are vasodilators. So you can try and give those. So this slide's also a bit busy, but it just again shows the nitric oxide and the prostacyclin as vasodilators, and looking at some of the second messenger systems, and then towards the bottom there, the final common pathway of the vasodilatation being mediated by phosphorylation of this myosin light chain kinase. The relevant bit about halfway down is that looking at the actions of both sildenafil and milrinone, which can also be used as pulmonary vasodilators. So they're both different kinds of phosphodiesterase inhibitors, and they inhibit the breakdown of cyclic GMP and cyclic AMP respectively. So by inhibiting that breakdown, that will tend to favour the pathway towards that phosphorylation and the vasodilatation. So just looking there, then looking back then at the different some of the different pulmonary vasodilators, the intravenous ones, prostacyclin, GTN, and sodium nitroprusside. I mean, all these things are going to act on the systemic circulation as well as the pulmonary circulation and tend to drop the systemic blood pressure, which we don't really want. So that's the advantage of giving them inhaled, that particularly nitric oxide and the prostacyclin, that they can just act locally on the pulmonary circulation, and there's very little systemic absorption or action. And then the oral ones, which are more of an issue for people with chronic pulmonary hypertension that you'll encounter people on sildenafil and bosentan, which I mentioned before as an endothelin antagonist. Another aspect of the treatment, so if you think we've been trying to address the cause, reduce the pulmonary vascular resistance, now we want to increase the right ventricular function, right ventricular contractility. So any of the common inotropes that we use, adrenaline, dobutamine, milrinone, levosimendan, these things are all going to have some right ventricular action. You need to be careful with dobutamine and milrinone and levosimendan, because again they tend to drop the systemic blood pressure, and you'll probably need to use it with a vasopressor to maintain the right coronary artery perfusion pressure that we've talked about as well. Final option really is a chance for sort of mechanical support if you're in an institution like St Vincent's or the Alfred, where you could put in an RVAD, so right ventricular assist device, or mechanical support for the right ventricle. Then that may be a bridge to recovery or to a transplant possibly. So in summary, just consider the patients that are at risk of chronic pulmonary hypertension. Be aware of the causes of acute pulmonary hypertension and right ventricular failure in the ICU, and particularly sort of acute on chronic failure, people with not much reserve in their right ventricular function. And then in terms of the management, the principles really are to try and reduce the pulmonary vascular resistance, optimise the cardiac output and the systemic perfusion pressure. Okay, thanks.